Hello and welcome back to BunMed, where we discuss concise medical knowledge that you can fit inside of a bun. In today's video, we're going to be looking at the thrombophilias. In the previous videos, we've had a look at disorders of impaired clotting. Now we're going to see what happens if we have too much clotting. So firstly, what is a thrombophilia? Well, thrombo refers to the formation of clots, and philia is a likeness towards or a tendency to. So in thrombophilias, we have formation of clots all over our body, or at least an increased risk of forming these clots. Now, these clots can build up in our venous system, such as those in the deep veins of our legs, giving us things like deep vein thrombosis or DVT. Parts of these thrombi may break off and make its way to our lungs, giving us things like pulmonary embolisms. In the arterial system, they may get lodged in the small arteries of our brain and cause things like strokes. And lastly, they may get lodged in our heart or the coronary arteries of our heart, giving us things like myocardial infarction. So these are very, very serious conditions. So whenever we have a thrombophilia, it's very important that we recognize it and are able to treat it. So now that we find out that thrombophilia is a condition where we form too many clots, let's find out what mechanisms are in place to stop this from happening, and why doesn't this happen every time we have a little cut, and why can we control how much we clot. So in order to break it down, let's have a look at the processes that we do in primary hemostasis and secondary hemostasis. Remember, primary hemostasis happens just after the cut, where we have the formation of that platelet plug, in which when platelets collide, they become activated, and this activated and platelets can accumulate together, aggregate together, and help to form the platelet clot. In normal circulation, when we have no pathologies, we obviously don't want them to clot, because then they could give us a thromboembolic event. So what can we do to reduce the risk of these platelets clotting? Well, the first thing that we do is constantly keep our blood moving, and the way that we do this is with a pumping heart. So as the heart pumps, there's a lower risk that the platelets will bump into each other because they're constantly circulating. The next thing that we can do is increase the distance between each platelet, because if we have an increased distance between the platelets, there's a lower risk that they'll bump into each other. So how do we do that? We do this with our endothelium producing these hormones known as endothelial nitrous oxide and prostacyclin, which cause vasodilation. And if we have vasodilation, our platelets are less likely to collide with each other, as they have more space to move about. What about in secondary hemostasis? Well, remember, secondary hemostasis is when we have the clotting cascade. And our whole goal is to get towards forming thrombin, because if we have thrombin formed, it can then activate our intrinsic pathway and really upscale how much more thrombin that we churn out. So what can we do to control how much fibrin that we form? Well, whenever we get the formation of thrombin, we actually get the formation of its antagonist, and this is known as antithrombin 3. And as the name suggests, it actually goes on to inhibit the formation of thrombin and inhibit thrombin itself. Thus, it reduces how much it kickstarts the intrinsic pathway. So we get a reduced activation of the intrinsic pathway, allowing us to control it. Antithrombin 3 also acts on factor 10A directly, inhibiting the common pathway and the formation of thrombin. Thus, we end up producing less thrombin and, as a consequence, less fibrin. Another process that we have going on in the background is the activation of protein C from inactive protein C by the mechanism of protein S. Once protein C is activated, it can go on to inhibit activated factor 5A, which, along with factor 10A, is needed to produce thrombin. By inhibiting the action of factor 5A, we again reduce the activity of the common pathway, and thus we reduce how much thrombin that we form. So now that we've had a look at what mechanisms there are to stop us forming clots, why do we actually end up forming clots excessively or when we shouldn't? Well, we can actually break this down into three categories, and conveniently this is known as Virchow's Triad. And what Virchow's Triad says is that if we have hypercoagulability in our blood, or we have stasis of the blood, or we have endothelial damage, we are more likely to clot. By hypercoagulability, we talk about a increased thickness of the blood or something going wrong with our clotting cascade. In stasis, if you're not moving that blood about, they build up and the platelets can bump into each other, forming clots. And in endothelial damage, as we have exposure of that collagen just outside of our endothelial layer, this activates the clotting cascade. So what can cause us to be hypercoagulable? Well, let's have a look at some blood. Here you can see in red we have the endothelium, we have a red blood cell when we have an antibody or proteins in the background floating about some yellow plasma. So what can increase the thickness of our blood? Well, if we have too many cells, like for instance in hematological malignancies or myeloproliferative disorders like Polycythaemia rubra Vera, where we have too many red blood cells, or primary thrombocythemia, where we have too many platelets, this increases the thickness of our blood and thus our likelihood of clotting. Another thing that we could happen is we could have too many antibodies or proteins in our blood. And this could happen in conditions such as multiple myeloma, where we have lots and lots of paraproteins, these dysfunctional antibodies that are just floating around our blood. This not only increases the thickness of our blood, but it might also bind to red blood cells and lead to what's known as rouleau formation, which is when red blood cells basically stack up on top of each other, looking like a stack of coins. Another condition that might do this is something like Anti-Phospholipid Syndrome with the presence of anti-cardiolipin and anti-phospholipid antibodies. We'll go on to look at all of these conditions in the coming slides. We could also have dysfunctional clotting. So if our anti-clotting mechanisms go wrong, so for instance, if we have factor V Leiden, slide coming up, or if we have protein CNS deficiency, or we have antithrombin 3 deficiency, we are at a higher risk of clotting because we can't turn off our clotting cascade effectively. Lastly, we could have normal levels of all of these. However, we could have reduced plasma. If we have reduced plasma, our blood becomes thicker, such as in the case of severe dehydration, and therefore we're more likely to clot. Okay, what about stasis? Well, if we have something like external compression from something like a solid tumor, we reduce the lumen size of our blood vessels. This means that as platelets pass under now the smaller lumen, there's a higher risk that they're going to bump into each other, become activated, and form clots. So that's how external compression and tumors may increase our risk of clotting. In general, though, having a malignancy increases your coagulable state, so you're hypercoagulable anyway, and you're more likely to clot. Another thing that we may happen is if we're immobile, we're not moving our calf muscles, we're not moving our body, therefore we're not forcing the blood pooling up in our legs to move up back towards our heart. As such, as the blood stagnates, there's a high risk that they may bump into the platelets may bump into each other and form a clot. So people who are immobile, those who are wheelchair bound, or those who are post-op or just about to be pre-op, are at a higher risk of clotting. Lastly, we may have something like atrial fibrillation, where our atria of the heart are not pumping properly. They're simply just fibrillating. As a result, blood stagnates and there's a higher risk that platelets might bump into each other. This is a major risk factor for having things like strokes or acute limb ischemia, where a clot blocks off the blood supply to one of our limbs. What about endothelial damage? What may damage our endothelium? The most simple and most common thing is probably something like trauma. If we have trauma, if we have something like an open fracture or something that damages our blood vessel, we're going to be revealing that collagen laying underneath. The next thing we might have is infection. So things like infective endocarditis, where we have an infection to the inmost layer of our heart. This damages the endothelium and we're more likely to clot. Things like recent surgery. This is a massive risk factor, not only because we're damaging the endothelium, but also we're immobile afterwards. So this increases our risk of clotting. Things like atherosclerosis, a stable plaque is not that big an issue, but in conditions like ischemic heart disease, when one of these plaques may become weak, one of these plaques may start to bleed, this severely increases our risk of getting a clot and thus lead to things like strokes or myocardial infarctions. And lastly, things like hyperhomocystinemia, which is where we have too much homocysteine in the blood that goes around damaging our blood vessels. So now that we've seen why we clot so much, how does this fit in with the thrombophilias? And when do we even look for a thrombophilia? So we may look for a thrombophilia in cases of unprovoked thromboembolic events. What we mean by this is when we can't see what has gone on to cause an embolic event. So for instance, if someone has a PE, a DVT, an arterial event such as a stroke or an MI in a young person, and there's no clear underlying cause, it's worth doing a thrombophilia screen. What do we look for in a thrombophilia screen? Well, what's included? Well, if we think back to the clotting cascade, we're going to be looking at protein C assay. Is there enough of it? Is it working properly? Same thing with a protein S assay and antithrombin 3 assay. Then we're going to look at the activity of factor V to look at factor V Leiden, and also try to find some of those antibodies in things like Anti-Phospholipid Syndrome, so lupus anticoagulant or antiphospholipid antibodies. Great, now let's have a look at factor V Leiden, one of these thrombophilias that we were talking about. What is factor V Leiden? Well, it's an autosomal dominant thrombophilia, so it's a genetically inherited thrombophilia, and it is in fact the most common thrombophilia in the United Kingdom, with about 5% of the population having it. So what's the pathophysiology and what actually goes wrong to give us an increased risk of clotting? To understand this, let's just have a very quick look at the clotting cascade again. Here you can see we have the intrinsic pathway on the left, our extrinsic pathway on the right, and of course the whole point is to form thrombin so we can kickstart the intrinsic pathway, right? So essentially, whenever this happens, we said that inactivated protein C gets converted into activated protein C by the action of protein S, and activated protein C then goes on to inhibit the action of activated factor Va, turning off this common pathway and thus reducing how much thrombin that we form. In factor V Leiden, we have a resistance from factor Va to activated protein C, and thus activated protein C cannot turn off the activity of factor Va. This means that we can't inhibit the formation of thrombin, and therefore we can't inhibit the formation of fibrin, so therefore both of these processes go up, and as such we're at a higher risk of clotting. So what sort of features might we notice, or what sort of symptoms may we notice with factor V Leiden? Well, in general, we actually don't tend to see any symptoms. Most patients tend to be asymptomatic until picked up incidentally by something like a thrombophilia screen. One of the most common things that they may have if they're having symptoms is things like thromboembolic events. So what do I mean by this? Well, it's things like DVTs or PEs. And what's really important about this is that these events may be recurrent. So they may have recurrent DVTs, recurrent PEs, or even have these events while being anticoagulated with things like warfarin or heparin. So what can we do to manage factor V Leiden? Well, in general, if it's picked up incidentally and there's no other things behind it, no specific treatment is needed. Only treatment is needed to treat the embolic event there. However, if they're being admitted to hospital, we need to be aware that they're at a higher risk of having embolic events, and therefore are more likely to need low molecular weight heparin, especially if they're pre-op. One thing to remember, though, is if they're having recurrent events, recurring DVTs or recurrent PEs, they may require lifelong anticoagulation. So factor V Leiden, not a great deal to know about this, just is the most common thrombophilia in the UK. Now let's get into one of the most physiologically interesting conditions that we have, something called primary polycythemia. Primary refers to the fact that it comes of its own accord, it's not from any other condition. Poly refers to lots of, cyth refers to cells, and emia in the blood. So what is primary polycythemia? Well, it's a chronic myeloproliferative disorder. So this is when it's of the myeloid lineage of our hematopoietic stem cells. And essentially, this is when we have too many red blood cells in our blood. Thus the polycyth bit, too many cells, right? So what goes wrong in order for us to have too many red blood cells? Because it's usually a very, very controlled process. Let's just very quickly remind ourselves how our red blood cells come to be. So remember, we have our kidneys, which produces erythropoietin, which travels in our blood and binds to our hematopoietic stem cells. Once bound, it actually activates this pathway known as the JAK-STAT pathway. And once activated, in a controlled fashion, these hematopoietic stem cells go on to differentiate into our red blood cells. In primary polycythemia, we actually have a mutation to the JAK-STAT pathway. Specifically, it's a mutation to the JAK2 V617F gene. When this gene gets mutated, what it essentially means is that the JAK-STAT pathway is always turned on, regardless of whether or not erythropoietin is present. And as such, our hematopoietic stem cells constantly and haphazardly turn out red blood cells that we don't need, increasing the viscosity of our blood and leaving us in a hypercoagulable state. Now, of course, the kidney detects this and it goes, hang on a second, we don't want these many red blood cells. So what the kidney might do to try to compensate is to actually reduce the amount of erythropoietin that the kidney is producing. So what sort of presenting features, what sort of symptoms may patients complain of? Things that's common in polycythemia is things like headaches, The absolute classic symptom that they complain of is this itch, is this constant pruritus. And the classical condition is something that we call aquagenic pruritus. So whenever a patient with polycythemia gets in a bath or a warm shower, they get this intense itch all over their body. If in an exam question you have someone who's coming in who sounds like they may have polycythemia, and then it uses things like, oh, they're getting a very bad itch when they get into the shower, or oh, they're getting a very bad itch in the bath, that's probably polycythemia. Take that option. Other things they might get is like thromboembolic events, because they're in such a hypercoagulable state. Their blood is so thick from the excessive red blood cells. Things like erythromelalgia may occur, which is this burning sensation on their hands and feet. And as well as that, they may get early satiety. The reason for this is we have too many red blood cells. What's happening to those red blood cells? Well, they're going to be eaten by our spleen, which gets bigger, pushes on our stomach, and reduces our ability to actually fill up our stomach, right? What are we going to look for on examination? Well, the first thing that we're going to look for is a ruddy facial complexion, by which I mean a red facial complexion due to the excess amount of red blood cells. The next thing we might look for is palmar erythema, where we have reddening of the palms due to the excessive red blood cells. Might also get splenomegaly, because as the spleen engulfs these red blood cells, it becomes hyperactive and it just gets bigger and bigger and bigger. What sort of investigations do we want to do for primary polycythemia? Well, the first thing that we want to do if we have someone who's complaining of aquagenic pruritus, has had thromboembolic events, or any symptoms of primary polycythemia, is do a full blood count. And the first thing that we're going to see is a raised hemoglobin. As well as this, we actually tend to see a raised hematocrit. Specifically, the British Society of Hematologists define this as a hematocrit percentage of greater than 52% in men or 48% in women. The next thing that we want to do is work out if this is a primary or a secondary polycythemia. Now, we'll talk a little bit about secondary polycythemia in a bit, but just to know, 90% of primary polycythemia cases actually arise from the JAK2 mutation. So therefore, we're going to do a JAK2 mutation gene screen to work out if they have the JAK2 mutation. Now, let's talk about secondary polycythemia. When may our body actually want and need more red blood cells? Well, it's when we're oxygen deprived, right? Because if we're oxygen deprived in conditions such as chronic obstructive pulmonary disease, being the classical case, then our body's going to go, we're going to hang on to any bit of oxygen that we can get, and therefore we're going to churn out red blood cells that are going to grab onto oxygen. So it churns out more. So how can we decide between if our body wants more red blood cells, or if our body doesn't want red blood cells? Well, if our body wants red blood cells, it's going to have to use erythropoietin, right? So in secondary polycythemia, our erythropoietin levels are very high because we want those red blood cells. In primary polycythemia, we don't want these red blood cells. They're simply going to get us clot, and therefore we're going to have other events. So in primary polycythemia, we have a low serum erythropoietin. How can we manage primary polycythemia? Well, what's the issue? We've got too many red blood cells, right? So let's take out some blood. We do repeated venesections. We also want to stop patients clotting, so they may get put on 75 milligrams of aspirin, a very low dose aspirin, to stop them from clotting. And lastly, we're going to very aggressively manage their cardiovascular risk factors, so stop them smoking, get them to lose weight, get them to eat more healthily to stop a cardiac or an arterial event from occurring. Great, now let's talk about primary thrombocythemia. Again, a very, very similar condition to the last one. Primary refers to the fact it's of its own accord. Thrombo, platelets, cells, and emia in the blood. So in what is primary thrombocythemia? Well, it's again a chronic myeloproliferative disorder where we have too many platelets, specifically dysfunctional platelets, in our blood. So how does this event occur, and why do we have too many platelets? Well, how do we normally produce platelets? Well, usually we get the production of thrombopoietin from our liver, which will travel in the blood and bind to, again, the JAK-STAT pathway, activating it and causing our hematopoietic stem cells to differentiate into the platelets in a much more controlled fashion. In primary thrombocythemia, we have the same mutations that we had in primary polycythemia, where we get the mutation in the JAK-STAT pathway, again the JAK2 V617F mutation, which leaves the JAK-STAT pathway constantly on, meaning that our cells haphazardly divide into platelets that we really don't need, and really increasing the viscosity of our blood, leaving us more likely to clot in a hypercoagulable state. As a result, our liver detects this and turns down the amount of thrombopoietin that it's going to produce. So again, a very similar picture to the one that we saw last time. what sort of presentations might we see from primary thrombocythemia? Well, just like last time, we might get headaches. We might get things like a thromboembolic event, because this time we actually have platelets, right? And they are much more likely to collide into each other and form lots and lots of clots all over our body. Weirdly enough, paradoxically, we might see bleeding in primary thrombocythemia, and this is because the platelets are actually dysfunctional sometimes. This is why this disease may sometimes be called hemorrhagic thrombocythemia, because of the risk of bleeding from dysfunctional platelets. We might also get things like erythromelalgia, as we saw in the previous condition. Early satiety, because these platelets are going to be eaten by our spleen. Might get livido reticularis. So this is a purple net-like rash that occurs over our hands and our legs because we get clots on our small veins of our body, essentially, and this forms a net-like pattern on our legs and arms. And lastly, we might see splenomegaly when we're palpating the abdomen, because the spleen is eating those platelets and churning and getting bigger and bigger. So what investigations are we going to want to do? Well, the first thing that we do is a full blood count, right? And in full blood count, we're going to see raised platelets. That's the first thing that we see, is a raised platelets. Then we have to work out, is this a primary or a secondary thrombocythemia? Well, what's the most common cause of a secondary thrombocythemia? It's going to be two things, really. It's going to be bleeding or iron deficiency, or an infection. So therefore, we can rule these two out fairly easily by doing something like iron studies and CRP. If iron studies is normal and CRP is normal, it's unlikely to be a secondary thrombocythemia. We can also look at fibrinogen, because fibrinogen is often raised in secondary thrombocythemia, where we're either bleeding too much or we have an infection. So if fibrinogen levels are normal or low, it's unlikely that it's going to be a secondary thrombocythemia. Then, of course, we can just do the JAK2 gene mutation screen again. And if this is positive, it's almost always going to be primary thrombocythemia. And lastly, we have to make sure that this isn't actually CML, or chronic myeloid leukemia. And the way that we do this is by doing something known as fluorescent in situ hybridization. So this test actually specifically looks for that Philadelphia chromosome, the 922 translocation, and thus it can rule out things like chronic myeloid leukemia. So what can we do to treat primary thrombocythemia? Well, again, we're going to want to give someone aspirin, so 75 milligrams low-dose aspirin, just to reduce their risk of clotting. We're going to aggressively manage their cardiovascular lifestyle factors, such as, again, those things like smoking, weight loss, healthy eating. Hydroxycarbamide can be used to reduce the amount of platelets that we're churning out. And in acute embolic events, we might actually do platelet pheresis, by which we mean directly take out the excessive platelets from their blood. Finally, to finish off the video, let's have a look at a very interesting thrombophilia known as Anti-Phospholipid Syndrome. So, what is Anti-Phospholipid Syndrome? Well, it's an autoimmune disorder against phospholipids in our cell membranes, right? And it can either be primary Anti-Phospholipid Syndrome, so by its own accord, or secondary. And secondary causes of this includes things like systemic lupus erythematosus. This is where you may have come across it first time, as if we did rheumatology first, you may have come across Anti-Phospholipid Syndrome there. Also, drugs can cause it, so things like procanamide and hydralazine may go on to cause Anti-Phospholipid Syndrome. So what's the pathophysiology? What's going wrong? Well, let's have a look at a normal platelet first and see how what's there and how Anti-Phospholipid Syndrome affects it. So here we can see we have a box standard platelet, and bound to it we have this protein known as beta-2 glycoprotein 1. In fact, it's bound to a cholesterol molecule on the platelet itself. The role of beta-2 glycoprotein 1 is actually to stop platelets from agglutinating and aggregating together, forming these platelet clots. In anti-phospholipid syndrome, we either develop antibodies against the beta-2 glycoprotein 1 or directly against the cholesterol molecule known as the anticardiolipin antibodies. As such, we are either inhibiting the action of beta-2 glycoprotein 1 or we're inhibiting its ability to bind to the cholesterol, thus we're not being able to stop how much platelets may agglutinate. This means that platelet aggregation is not inhibited, and thus platelets are much more likely to clot when they bump into each other. So, and this can, of course, lead to some embolic events. So this can, again, lead to DVTs and PEs, but also in pregnant ladies, this can actually block off the blood supply to the placenta, causing things like miscarriages due to placental infarction, which is quite sad. Right, in terms of presentations, what are we looking for? Well, of course, the first thing that we're looking for is thromboembolic events. These platelets are not being inhibited, so they're constantly agglutinating and forming these clots all over our body. So things like PEs, DVTs, MIs, and strokes are always a good thing to ask in terms of past medical history. We're always looking for a past medical history of any miscarriages, because remember, these thrombi can actually go on to cause infarction of the placenta. Another thing is the classic thing they use in exam question is this appearance of a new rash. Again, livido reticularis, where these platelet deposits can get deposited inside the small and superficial veins of our arms and legs, forming this purple net-like rash over our arms and legs. Other things that we might see is headaches, and we're not quite sure why this actually occurs. So in terms of investigations, what can we do to investigate antiphospholipid syndrome? Well, in terms of investigations, the first thing we're going to do is a full blood count, right? And in a full blood count, we might see an anemia of chronic disease, and we might see a thrombocytopenia, classically, especially if these antibodies are directly targeting our platelets. Now, this next bit is a bit weird, because if we do some clotting studies, we'll see that it has a raised APTT. Now, you're probably thinking, hang on a minute, this makes no sense. This is a condition that increases our risk of clotting. Why then do we have a raised APTT, which we would expect in a bleeding disorder? Well, remember that these anti-phospholipid antibodies work on the platelets. When we are testing APTT, we actually only use plasma. So we use the donor's plasma, and then we use someone else's plasma. So as a result, this plasma doesn't actually have any platelets in it. If it doesn't have platelets in it, these antibodies can't actually do their job in terms of making the blood much more viscous. So instead, they actually make it much thinner. So here's the paradoxical bit. Even though antiphospholipid syndrome puts you at a higher risk of clotting, it causes a thrombocytopenia and a raised APTT. Of course, then we can do an auto-antibody assay and directly look for the beta-2 glycoprotein 1 antibodies, antiphospholipid antibodies, as well as the anticardiolipin antibodies. So what can we do to manage it? Well, if we have an acute thrombosis or a DVT-PE, first thing that we do is use low molecular weight heparin. So this is, just remember this formula for any other embolic event. The first thing you do is give them low molecular weight heparin. You then give low molecular weight heparin until their INR is in range for 48 hours, at which, alongside warfarin, at which point you can switch them over to warfarin. If they're in pregnancy, do not give warfarin because there's a high risk of tetragenicity, which essentially means that there might be birth defects in the baby. So wait until the baby's been delivered, keep them on heparin, then give them warfarin. So thank you very much. That concludes the video. I hope you found it helpful in order to just understand some of the thrombophilias, how they occur, because they are extremely interesting. If you have any questions, please leave them down below and I'll try to answer them as soon as possible.